So this is a randomized trial that was delivered through the UK Trials Acceleration Programme funded by Bloodwise, and it addressed a fundamentally important question of how can we increase the clinical activity of azacitidine in older patients with acute myeloid leukemia. So azacitidine represents a real advance in the treatment of older people with AML who aren't eligible to undergo intensive chemotherapy, and there's recent randomized data showing improved survival. But although it's the first advance in this sector for 30 years, we should not be blind to the fact that the complete remission rates are still only in the region of 25%. And despite the fact that many patients have excellent responses, all ultimately will relapse. So there's an urgent need to identify new strategies to improve outcome in patients with AML treated with azacitidine. And there have been some very encouraging laboratory data and some small early phase trials suggest adding a histone deacetylase inhibitor, which seems to have synergies in terms of remodeling chromatin, augments the anti-leukemic activity of azacitidine. So RAvVA is a prospective randomized trial asking a question of whether adding the histone deacetylase inhibitor Vorinostat augments the clinical activity of azacitidine in patients with high-risk AML and MDS. Primary endpoints were overall response at 3 or 6 months and overall survival. At the same time, we wanted to understand more about how these drugs were working, what the mechanism of relapse was, and so working with Parish Virus in Oxford, we've quantitated leukemic stem progenitor cells for the first time in a large prospective AML trial. So what we observed was that although Vorinostat was reasonably well tolerated, it didn't increase overall response rate and didn't increase overall survival. And I think the message from that would suggest that in the setting of AML, it's probably not worth investing much further effort in terms of identifying whether histone deacetylase inhibitors, unless they're going to have a starkly different method of action in the next generation of these agents, probably not at the moment worth investing further looking at combinations of these drugs with azacitidine, and we should be looking at different strategies. But what was really interesting was the biology which we were able to deliver. We had greater than 80% sample return, and what we observed was that although there was a substantial reduction in leukemic stem progenitors in patients achieving CR, azacitidine doesn't appear to eradicate this population. We've looked in patients treated with chemotherapy went on to have durable remissions, and in that population, after intensive chemotherapy, we don't see persistence of leukemic stem progenitor cells. So that might be telling us something about the mechanism of resistance. And secondly, it suggests that if we're going to improve outcomes and prevent relapse, we need to think of ways of targeting that population in azacitidine-treated patients. And finally, in patients destined to relapse shortly before they had a morphological relapse in the bone marrow, we saw a rise in the stem progenitor numbers, which suggests this may be a useful biomarker relapse, but we need to look at that more carefully. So the study was delivered on time and target with excellent biological outputs, and I think it demonstrates the strength of cohesive trials networks across the UK investing in our large leukemia centres across the country to drive forward practice-informing prospective trials.